Laproscopic cholecystectomy. Laproscopic cholecystectomy has dramatically changed the approach to the management of cholecystitis. It has become the new standard for therapy of symptomatic gallstones. If the common bile duct is thought to be obstructed by a gallstone, an ERCP with sphincterectomy may be performed to explore the duct before laparoscopy. Before the procedure, the patient is informed that an open abdominal procedure may be necessary and general anesthesia is administered. Laparoscopic cholecystectomy is performed through a small incision or puncture made through the abdominal wall in the umbilicus. The abdominal cavity is insufflated with carbon dioxide, that is, it causes pneumoperitoneum to assist in inserting the laparoscope and to aid the surgeon in visualizing the abdominal structures. The fiber optic scope is inserted through a small umbilical incision. Several additional punctures or small incisions are made in the abdominal wall to introduce other surgical instruments into the operative field. The surgeon visualizes the biliary system through the laparoscope. A camera attached to the scope permits a view of the intra-abdominal field to be transmitted to a television monitor. After the cystic duct is dissected, the common bile duct is imaged by ultrasound or cholangiography to evaluate the anatomy and identify stones. The cystic artery is dissected, free and clipped. The gallbladder is separated away from the hepatic bed and dissected. The gallbladder is then removed from the abdominal cavity after bile and small stones are aspirated. Stone or forceps also can be used to remove or crush the large stones. The advantage of laparoscopic procedure is that the patient does not experience the paralytic ileus that occurs with open abdominal surgery and has less postoperative abdominal pain. The patient is often discharged from the hospital on the day of surgery or within a day or two and can resume full activity and employment within a week of surgery. Conversion to a traditional abdominal surgical procedure may be necessary if problems are encountered during the laparoscopic procedure. This occurs in 2 to 8% of reported surgical cases. Conversion is required more often, approximately 20% of the time, in those with acute cholecystitis. Careful screening of patients and identification of those at low risk for complications limits the frequency of conversion to an open abdominal procedure. With wider use of laparoscopic procedures, however, there may be an increase in number of such conversions. The most serious complication after laparoscopic cholecystectomy is a bile duct injury. Because of the short hospital stay, it is important to provide written as well as verbal instructions about managing postoperative pain and reporting signs and symptoms of intra-abdominal complications including loss of appetite, vomiting, pain, distension of the abdomen and temperature elevation. Although recovery from laparoscopic cholecystectomy is rapid, patients are drowsy afterward. The nurse must ensure that the patient has assistance at home during the first 24 to 48 hours. If pain occurs in the right shoulder or scapular area, this from migration of the CO2 used to insufflate the abdominal cavity during the procedure. The nurse may be recommend use of heating pad for 15 to 20 minutes hourly, walking and sitting up in the bed. Thank you.